everyone. Welcome, welcome. My name is Michael Schwartz. I'm the Experiential Director of Better Spaces. I see we have a few new people coming into the room. Hi, Penny. Hi, Nicole. Whether you're watching this live or you're watching the replay in the app, thanks so much for being here. So if you're new to Better Spaces, we partner with buildings and companies to create programs that help you connect, create, and perform at your highest potential. Today, in our Build a Resilient Body series, we have Paul Kachoa doing a program on knees. Dr. Paul Kachoa received his doctorate of physical therapy from Mercy College, and he also has a BS in exercise physiology from Rutgers. His treatment philosophy is move better, feel better, and play better. If you have any questions throughout this program, feel free to add them in the chat window, and I'll get to them at the end. All right, without further ado, Dr. Paul, take it away.
All right, thank you, Michael. My name is Dr. Paul Kachoa, and I'm a physical therapist, and welcome to the next installment of How to Build a Resilient Body. Today, we're going to be talking about knees. So let me get my slides up here. We'll get this started. So Resilient Body series, we did foot and ankle last week. So a lot of that is going to be connected to what we're going to be covering today. Let's see if I can get this started. And here we go. Again, because I'm a physical therapist, a medical provider, I have to do this disclaimer that this is not physical therapy. These are just common tips and things and exercises that you can do on your own to help alleviate some knee issues if you're having. They're generalized information. If you are dealing with a specific issue or medical condition, please consult a medical professional. So, and if you've been to my other classes, this is the one thing that I always say, that the body functions on this alternating pattern of stability and mobility. If that pattern is disrupted, then pain or injury is the result. So if you have some knee issues, don't just think that you need to focus on the knee, get an MRI or get an X-ray, it's a knee problem, because a lot of times what we find is that it might be something else in the ankle or the hip. And what I mean by that is this is a video illustrating the alternating pattern of stability and mobility, starting from the foot and ankle all the way up to the wrist and the hand. So if we look at the knee is a very simple joint. All it does is just bend and straighten, right? But what happens is that foot or ankle, if that becomes, well, if the ankle becomes stiff, that's supposed to be a mobile segment, or the hip becomes stiff, that's supposed to be mobile segment too, your body will start to seek the path of least resistance. So it'll try and make the knee a mobile segment, but it's supposed to be stable. All it does is bend and straighten. When that angle of that bending and straightening goes off to the side or off axis, then that's when we run into some knee issues. So we're going to talk about stretches and mobility today. Remember, don't push through the pain. If we're going to stretch out soft tissue, we want to hold that soft tissue stretch for at least 30 seconds. And then if we're going to do a joint mobilization where we're trying to move a joint, we're going to do that for at least 2 minutes. All right, so our first test, and if you were here last time, we talked about the squat test. And then today we're going to specifically look at some knee extension and knee flexion. Extension is a fancy term of just straightening, so when the knee straightens, and flexion is a fancy term for when the knee bends. All right, so what does your squat look like? So this is what a squat should look like. You're going to stand up, get your feet together, hands out in front of you, making a fist, and then you're going to squat down. Ideally, we should be able to physiologically get the hips below the knees in the standing position, and finally get the fists on the ground. So I'm going to go to my two-shot here for a second so I can demonstrate this. We're going to go fists out in front, feet together, and then we're going to squat down. Now, we're going to check how much knee and hip flexion you can have later on and determine why some people cannot get into this position. All right, so let's go back to my slides. What does your squat look like? A lot of times people will get into positions. Let me see if I can, there we go. Where the knees don't follow the toes. So there's this big fallacy or this big myth that your knees should never go over your toes when you're squatting or lunging. So the research shows that the compressive force on the knee changes as we go down into our range of motion, and it is not inherently bad for the knee to go in front of the toe line. So we can talk a little bit more about that. And this is another test for how much knee flexion you have. Can you get down onto your knees, and can you bring your hips down to your heels? So this is a full knee flexion, like a child's pose position. This is someone stretching in one of the classes. So if you don't have this, then we can kind of see what can we do to improve that. We talked about this last week, or maybe a couple weeks ago, when we talked about hips, the Thomas test. So if you're on the edge of a chair or edge of a bed, and you bring one knee into your chest and you lie back, ideally, we want the knee and hip to look like that top left position, that top left picture. If the knee doesn't bend 90 degrees, like that top right picture, then that means that we have a tight quadricep muscle. A tight quadricep muscle, that's your thigh muscle. If that's too tight, that can increase the compressive force on the knee and create some issues. If the bottom left picture is more like what you find, that means that your hip is tight, your hip flexor. And the bottom right, if the knee or thigh is parallel to the ground, but jutting off center, so it's not in line with the hip, knee, hip, shoulder, and knee, if it's not in a straight line, that means that your tensor fascia lata is tight. And that's what this muscle is. A tensor fascia lata, or TFL for short, is a muscle that's inside the iliotibial band, the IT band. And this is responsible for a lot of knee pain in runners or people who stand a lot. So the iliotibial band is this very dense, connective, strong structure. It's sort of like a ligament tendon hybrid. It connects the top of your pelvis down to the side of your knee, and it's very durable. So if you've heard people like, oh, you should roll out your IT bed, the amount of force to deform or stretch out that tissue is over 2,000 metric Newton tons or something like that. So I know it's a lot of force that you need to apply to it to deform it. So the low-hanging fruit when we're trying to increase mobility through that IT band is to go after the muscle. We want to mobilize the glute and the TFL and the lateral quad, which passes underneath that IT band. So these are the things that we're going to get into today. The TFL, soft tissue mobilization, some quad muscle, soft tissue mobilization, some knee joint mobilization, and some soft tissue mobilization for the general lower body. So I'm going to go back to my 2-shot here. So I've got my foam roller right here. Foam rollers are ubiquitous. You can get them anywhere. And I have a lacrosse ball. Now the TFL muscle sits into this lateral hip. So if you find your pelvic rim right here, it's right below that. And if you feel for the outside bony part of your hip, it's between that and to the front part of your, pretty much in the pocket area. So you can get down onto the floor. You could use this foam roller and then just use the end of it here and then kind of go back and forth. Now, soft tissue, if it's stretched, is more uncomfortable. It tolerates the pressure less than if it is on slack. So to create slack through that IT band and that TFL, I'm going to bend my knee and hip. And then from here, I can go rolling up and down. It's this very small, short muscle, so I don't need a lot of motion, but I could also do forward and backward. That creates shearing across the fibers. The fibers generally run straight up and down, and if I go forward and backward, I'm going to get a little bit more opening or shearing or soft tissue mobilization into those fibers. Now, if I could tolerate this, then I can go to my next level, is using a lacrosse ball or a trigger point ball or some type of tennis ball. I can get rid of that, and it's the same position. I'm just going to put that right in that pocket area. And because it's a smaller piece of implement that I'm using, I'm going to need to apply a little bit more pressure if I can tolerate it, and then do the same thing. Go up and down, side to side, left to right. And then as I get comfortable with that, then I can gradually straighten out this knee, which makes it a little bit more uncomfortable because I am putting the tissue on some tension, and I bring this foot out in front. So that creates a lot of stretch to my IT band and the TFL muscle. And that makes the mobilization a little bit more effective. Now we can go back to the quadricep using this foam roller here. I'll show you on my other side here. The quadricep pretty much runs from the front part of your thigh here on just above the knee to the front part of your pelvis. We could use the foam roller to mobilize that. So I'm going to go back and forth, up and down. I can go left to right. It's a three-dimensional muscle. So I want you to kind of explore areas where you feel that if you have some tightness, you're going to stay on that and oscillate over that. And anytime that you're doing any soft tissue work, it's going to be for 2 minutes, 2 minutes. And if I find a spot that might be tight, I can knead into that a little bit, just oscillate over that. I feel a little bit tightness on that lateral quad from here. And then if I can, I'm going to start to bend and straighten that knee, which elongates that fiber over our trigger point. And that helps to relieve some of that. Okay. And then now let's get into the knee. Let's go into this shot here. See if I can pull this in. So this is a lot. I'm going to get it close up onto my knee, and I could use my lacrosse ball to do this. So we have my kneecap right here. My quadricep inserts into my kneecap. Anytime, typically, people will get pain right below that kneecap, signifying that there's a patellar tendon issue, or above the kneecap, which would be a quadricep tendon issue. And if we get pain across the inside of the knee, that knee joint line right here, that could be some degenerative changes that have happened, like meniscus, osteoarthritis, something like that. But if, again, this is something that you can try at home. Your body really likes to have some sliding and the ability for those tissues to move around. So you can see like how I'm just taking the skin around my kneecap and I'm just moving it. I'm not just kind of just rubbing it like a massage, but I'm taking the tissue and taking up that slack and starting to move that. I could do this with my lacrosse ball. If you have a fresh one or a new one, the coating on there is really tacky, really rubbery and tacky. I could take that around my kneecap and mobilize that tissue by creating some stickiness, so I'm creating some shearing on that tissue using the rubber here. So I could slide up and down, I can go side to side, I can do a twist. Right, so we want all those layers of tissue to move on one another. The deep layers to move over the move under the superficial layers, and the superficial layers to move over the underneath layers, the deep layers. So patellar tendon, I can come around here, I can go over the bony areas and create shearing. So I'm not rolling the ball. If you could see that on a camera, I'm creating just a sliding. So I'm catching the tissue slack and I'm moving that around. I'm shearing that tissue up and down, and that will create more mobility in that tissue and hopefully loosen up the patellar tendon, quadricep tendon, and you can even do it on the inside here because we've got a whole bunch of ligaments and tendons on the inside of your knee as well. All right, so those are some things that you can do. Let's go back to this for your knee in terms of soft tissue work. Oh, I forgot almost to work on some knee mobilization, right? Let's go back to this, get rid of this. So one of the tests that we did last time is to make sure that you can bend your knee all the way and bend your hip. So this is just one of the tests here. Can I get my calf to my hamstring, right? If I cannot do that, then I'm going to create a little bit of gapping. I like to use my hand there and then kind of just pull that in and then see if that helps to mobilize the joint. Okay, so that's proper joint mobilization. You can do this in a half kneeling position as well. I'm going to put my fingers behind there, my hand behind the knee, and as I push forward like this, that creates that gapping and that joint mobilization to facilitate full end range flexion. And if I look at my knee, if my knee does not go all the way straight, then I want to try and make it go straight. Passively, if you push down in this position, you should get at least 5 to 10 degrees of hyperextension in the knee passively. That's normal range of motion. So if there isn't, then the test actually turns into a way to treat it. We just kind of go over it, sort of like I'm going to give CPR to my knee. My hands are kind of crisscrossed right above my kneecap. And then I'm just going to oscillate into that end range. It's kind of just like doing a CPR. And that helps to mobilize that knee joint and get back knee extension. I see that a lot with patients who have come in to see me post knee surgery. They're missing a couple degrees of extension. And that's one way to get it back.